So that is present in your blood. That's obviously present in your red blood cells. That's present in lots and lots and lots of cells. Yes? Yes. That's okay. Just tell me if that is the case. If you can't hear me, that's totally fine. All right, so the question was, how does CO2 get converted to hydrogen ion in the cerebrospinal fluid? And the answer is that there's carbonic anhydrase that's present there, and that's the enzyme that speeds up the reaction in either direction. Now, if there is water around, CO2 will combine with it and start forming hydrogen ion and bicarb on its own. It doesn't have to have carbonic anhydrase present, and because all of our cells have water in it, if CO2 is around, there can be a recombining event. It'll happen way slower if carbonic anhydrase isn't present, but it will still happen in any cell type anywhere within the body if CO2 meets up with water. Yeah. Good. Now, the most important things for the central chemoreceptors are that if you have high levels of CO2, that is what's diffusing into the cerebrospinal fluid, not hydrogen ions, and that's number one. It's that CO2 is converting from CO2 to bicarbonate and hydrogen ion, and it's the hydrogen ion that the brain is sensing, not CO2 levels in the cerebrospinal fluid. Are you confused? Does that make sense? I was pointing at you, but does that make sense? Okay, good. Sometimes people give me a look like they don't understand, so I just want to make sure that everybody's on the same page. All right. Now, and that you should understand if CO2 levels go up in the plasma, that we should stimulate ventilation. Yes? Yes, so CO2 levels should, I can't remember what I just said. CO2 diffuses into the cells, converted to hydrogen ion. It's the hydrogen ion that's activating the receptor, not CO2. Okay? This is contrary to what your book says, because what your book says is not true. CO2 is not activating the receptors that are present in your brain. It's only hydrogen ion in the cerebrospinal fluid. Okay? CO2 is converted to hydrogen ion that activates the central chemoreceptor. And that central chemoreceptor then talks to the respiratory control center, and the respiratory control center then modulates ventilation. Does that make sense? Yes?
Sort of, but then didn't you say that like the central, like it depicts CO2, sorry to say that?
So the central chemoreceptors kind of indirectly monitor CO2 levels in the plasma. Okay, does that make sense? It's not actually CO2 that's activating the receptor itself, but it's a reflection of CO2 levels that are present in the plasma. Yes, and that's why they're sensitive to CO2 levels, because changes in CO2 levels will modulate hydrogen ion concentration, which will then result in either increase or decrease activation of those receptors. Good. Okay. Yes?
So why do we say the peripheral chemoreceptors sense pH and the central chemoreceptors don't? Because isn't hydrogen ions produce pH?
Yes. So, I guess in that way, I can see where that'd be confusing. So it's not this, because hydrogen ions aren't diffusing into the brain, they kind of think that's why they argue that it's actually not sensing pH. But if it's sensing CO2, CO2 is related to pH, so they would be kind of sensing pH in a way, because if more CO2 is being converted, H plus is being converted to CO2 that's diffusing in, that can modulate it. But it's just by convention the way that we've talked about it, that all textbooks kind of talk about central and peripheral chemoreceptors. But you are correct. And kind of that way of thinking is correct. Yeah. Okay. All right. Can you guys still hear me? Good? Okay. All right. So I should have taken pictures of the questions that we had for repro. Does anybody have any other pulmonary related questions? Yes? Yes. Okay. Minute ventilation versus alveolar ventilation. Basically, what you need to know, what we're looking at, is how much air is moving in and out of the lungs. And there's two regions that we're really interested in focusing in. One is minute ventilation, and minute ventilation really only talks about air moving in and out of the lungs. It doesn't care if it's exchanging with oxygen or it's exchanging in the blood. All that we care about is this air moving in and out of the body. All right, does that make sense? All right, okay, that's minute ventilation. So all we need to know for minute ventilation, out of volume, amount of air that you're taking in for every breath times the number of times you're breathing per minute will give you the amount of air that's moving in and out of your lungs per minute. Does that make sense? Okay, this is minute ventilation. Now, every time you take a breath, some air gets trapped in an area that does not participate in gas exchange. What do we call that area? Dead space. Good. So that area we call dead space. Now, the kind of business end of the lung is at the alveoli, right? That's where the gas exchange is happening. And so it makes sense that some people are only interested in measuring how much air actually makes its way to the alveoli. Does that make sense? So the other type of ventilation that we monitor is alveolar ventilation. All right. Now, if tidal volume is the total amount of air that's moving into your lungs, okay, the amount that reaches your alveoli is the amount of air minus the dead space. So whatever is getting trapped in, if you take in this much air, this much gets trapped in your dead space, and this much here makes it to your alveoli. So we're really interested in just this little piece down here. How much is actually making it to your alveoli? So in order to calculate that, we need to factor in dead space. So we take tidal volume, the total amount, we subtract off dead space. This is alveolar volume. Should kind of make sense, right? That's the amount that's going to the alveoli. And we multiply that by your respiratory rate. Do you see now how we take the amount of air that reaches your alveolus, we multiply that by the amount of times that you're breathing per minute, and we get the amount of air per minute that is actually reaching your alveoli and participating in gas exchange. Okay. Now, if I ask you to calculate minute ventilation, all you need is tidal volume and respiratory rate. If I ask you to calculate alveolar ventilation, you have to have dead space. Does that make sense? If I ask you, yes? No. So dead space, part of your dead space would be residual volume, but residual volume is not dead space. Does that make sense? So in other words, is you might have air that's in your alveoli that you can't breathe out. And that would be part of your residual volume. You will also, when you breathe out as much air as you possibly can, have some air stuck in your trachea. Does that make sense? And that would be dead space. But the amount of air that's by your alveolus, that's part of that would be part of the air that's present in the gas exchange area within the lungs, the non-conducting airway piece. Does that make sense? Okay. Yes.
So dead space would have to be like a value that's given to us.
Dead space would be a value I would give to you. Yes. Correct. The only other way that I could think of it, I didn't ask something like this, but like theoretically, would be if I said, if I gave you a minute ventilation and I gave you an alveolar ventilation, and I said like which one's bigger, which one would have to be bigger, you know, something like that. Like it would be impossible that somebody would have no dead space. So minute ventilation should always be a larger value. Something like that I could potentially ask, but I didn't. So yeah, okay. Any other questions about that?
So do you get dead space because of the concentration gradients? Like once it reaches equilibrium, that's why we have dead space with stuff? Or?
So the question is, where is the dead space? The dead space, so when you have air you bring in through your trachea and then it branches, right? And then there's these branchings. We have areas that are called conducting airways, and all they're really doing is conducting the airflow down to the region of the lungs that actually can participate in gas exchange. So all of the conducting airways, everywhere where there's no alveoli is a conducting airway, and that part of the airway does not participate in gas exchange. And that part of the airway we consider dead space. Now, if we had an alveoli that was damaged, such that there was no gas exchange, this would also be considered dead space. Okay, but it's this idea that anywhere within the lung where you're not participating in gas exchange or where you can't participate, then we call that dead space. Yes.
And if an alveoli was damaged, it would then constrict and divert the air somewhere else, right?
Yes. Okay. So the way that I taught it in class, that will happen physiologically. but the way that I talked about it in class is that your vessel going to that airway would constrict.
Okay.
That makes sense? Your book also talks about airway constriction, which does happen, but I talked about hypoxic. So hypoxic, vasoconstriction. So hypoxic, the alveoli becomes hypoxic, or for whatever reason it's damaged, and this thing thinks that there's no oxygen there because there's none diffusing. This blood vessel will constrict and divert blood to a different part of the lung. Good. All right. Anything else? Yes.
This is kind of a long one, so if other people don't have this question, that's okay. But I was wondering if you could go over the pathway of CO2 from like the atmosphere to the lungs and
Yes.
all the numbers and stuff.
So we went through that in the first part, but if you stick around after, or if you don't have time to stick around, just watch the first part of that review when I post this, and then you'll have that question answered. So just so that we don't, because that is a longer question, but we can definitely answer that if we have time at the end. Yes.
Can you go over restrictive versus obstructive?
Yes. So restrictive versus obstructive. Okay. Alright, so I gave you this graph that looks normal here. Okay, so for the exam, I will expect that you should be able to label different volumes and capacities. So I expect that you would know what total lung capacity, what are the volumes involved in that. I would expect that you would be able to tell me what a vital capacity was, or a forced vital capacity. Where is that on this graph, all right? Or tidal volume. All of those volumes, or residual volume, I expect that you'll be able to identify those on the graph, okay? So, do you want me to go through those, or should we? Okay. I'll just tell you the ones since we were talking about restrictive versus obstructive. Here is a normal spirometry that we might look for somebody. Okay. Here's the tidal volume. Okay. I'll just label the 4 main ones, and then everything else is made up of all these other volumes combined. So we have residual volume down here. Expiratory reserve volume. If you want to remember that, all you have to think is, I've said this to other people, but the reserves for, I don't even know if it's actually true, the reserves for the military, I think of like your backup, okay? So at the bottom of your normal exhale, what air do you have as kind of your backup if you needed to exhale more out, okay? So that's your expiratory, because you're breathing out. Reserve, kind of what your backup is, volume. Does that make sense? Now you can think of the same thing. If you inhale normally, what other amount of air that you can actually inhale above normal breathing? That would be your inspiratory reserve volume. Okay, all the way up to total lung capacity. All right, this volume here, from the top of your breath all the way down to as much air as you can possibly breathe out, is your vital capacity. And if you're forcing yourself to do it as fast as possible, it's a forced vital capacity. That's important for a clinical value. Okay, now, this is tidal volume. So, inspiratory reserve volume, tidal volume, ERV, expiratory reserve volume, and residual volume. These 4 are the 4 that you need to know to make up all the other capacities. Do you see how vital capacity is the capacity is these 3 volumes added together? Right? Total lung capacity is all 4 added together, and so on and so on, okay? These are the ones that are important. Now, if you have somebody with a restrictive disease, what kind of characteristics can you think of that this person would have? Yes? Stiff lung tissue, okay? This tissue is stiff, meaning it's hard to expand. So, do you think this person is going to have an easy or difficult time breathing up to total lung capacity? Say it out loud. Difficult, okay? So, difficult time. So, they'll probably even have a difficult time breathing normally. Like, their tidal volume might, depending on the severity, might even be a little depressed, okay? Now, you ask this person who has a very stiff lung, low compliance, breathe into total lung capacity. They breathe in, breathe in, breathe in, breathe in, but they just can't make it to a normal lung capacity. Now what you do is you tell this person, now exhale out the exhale out the air as fast as you possibly can. Okay? So they exhale it all out. Now, is this person going to have trouble exhaling out their air? No, it's relatively easy to exhale out because remember, because it's stiff, it's hard to inflate, but if you let it go, if you release it, it will there's increased elastic recoil, and that lung will kind of come back to its normal shape. So easy for them to exhale, difficult to inhale. So when they exhale down, they might exhale down to residual capacity. In class, we talked about dipping a little bit below that. But the speed at which they exhale out air out of their lungs is going to look very normal. Okay? They don't have issues doing this. So they will have a decreased total lung capacity. I would hope that you'd see that. All right. Now, the other value that we're interested in here is FEV1, forced expiratory volume in 1 second. All right. In a normal person, this should be about 80%. So this is about 80%, this is about 20% left of their vital capacity. Okay? 80% of the air should come out of a normal person within 1 second. All right, so this should hit this line, but whatever. Okay? All right, it doesn't really matter. Okay, so 80% of a normal person's air at the top of their total lung capacity should be exhaled out within the first second. Now, for somebody with a restrictive disease, do you see how they can also exhale out 80% of their air, or the amount that the rate, so I'm saying this wrong, okay. FEV1 is the amount of air that they exhale out within 1 second. That's a volume, it's an amount of air, okay. This person, normal, is exhaling out some X amount of air. Do you see how this person with a disease, their FEV1 will be less? Does that make sense? They won't be able, because they couldn't get up to total lung capacity. So there's this much amount of air that they're not going to be able to exhale out within the first second. The rate at which they're exhaling that out might be similar. Okay? Does that make sense? So if I look at the ratio, the amount of air that they breathe out within 1 second over the total amount, that ratio for somebody with a restrictive disease might look like a healthy person because they are able to also exhale out 80% of their air within the first second. Okay, so they might look like a normal person. So FEV1 over FVC might look normal at 80%. Okay, it might even be a little greater than 80%. That's fine. But the idea here is that if you just looked at FEV1 over FVC, you might overlook the fact that this person has a restrictive disease because it might look normal. So for this, what you should do is you should measure a couple of different values. Normally, you'll get an FEV1, that's one value. You will also get an FVC value. Now, the diseased person compared to the normal person, who's going to have a larger FVC? Normal, right? So this normal person exhales out more air than somebody with a disease state. Okay, so if you looked at FVC, you'd say, oh, that looks like this person isn't exhaling out as much air. So you could also look at the FEV1 actual value. That should also be less. And if you compared those, so if somebody has lower FEV1, lower FVC, but normal FEV1 over FVC, this person would be restrictive. Does that make sense? Now, I really don't want you to memorize this because that might not, it's about understanding why these things are the way they are. Not about just like memorizing this and saying, okay, that's all I need to know for the exam. Okay? It might help you for one question, but if I ask you about the physiology and to thinking about how this works, it's not going to help you in those questions, all right? All right. For an obstructive disease now, maybe I should have left that. Okay, this is restrictive. Now, for obstructive, I'll do obstructive in orange here, if this works. All right. Is a person with an obstructive disease, what's a characteristic of somebody with an obstructive disease. Tissue, that's a restrictive disease, is a tissue issue.
Airway issue.
It's an airway issue, okay? So restrictive disease is a problem with your tissue. That's why the tissue is stiff. You see how that makes sense? Your tissue is stiff, that's why you can't inflate your lungs. That's a restrictive disease. Now, an obstructive, you're obstructing the flow of air in your airways, okay? Now, this becomes a problem in the airways. You narrow your airways, and now you have troubles breathing, okay? So, is this person, is it going to be hard to inhale?
Yes.
Yes, it's going to be hard to inhale. Is it going to be hard to exhale? Yes, good, thank you. So, this person's going to have trouble inhaling and exhaling, inhaling and exhaling. Okay, is this person going to breathe all the way up to total lung capacity? No, it's hard to inhale, hard to exhale. They're breathing through a straw. They can't breathe up to total lung capacity. Now, can this person exhale very well or very quickly? So if you breathe through a straw and you exhale, it's going to take you a long time to get down to residual volume. Does that make sense? So this person is going to have a much harder time exhaling the air out. So it's going to take longer for them to get down to their residual volume. Now, they might not get down to a normal residual volume because it takes so long they feel like they need to take another breath. Okay? So, now this person goes back to normal breathing after. And now if we compare these graphs, what do we see? What do you think happens to this person, somebody with an obstructive disease, FEV1? What happens to their FEV1? The amount of air that they exhale out within the first second, if they're trying as hard as they can, compared to a normal person, what do you think it's going to be? Less than normal. It's going to be depressed, right? So they can't exhale out their air. So FEV1, yes, will be lower. Okay, what about FVC? This amount right here. Decreased, right? They can't breathe up to total lung capacity and they can't breathe all the way down. So that amount is significantly decreased, okay? Lower FVC. What happens when you look at the ratio? This goes way down. Does that make sense? So if you had somebody who came in and they had a really low FEV1 over FVC, a low FEV1 and a low FVC, that would be a profile of somebody with an obstructive disease, right? Now, let's say a person who has asthma, narrowing of their airways. Another thing they will have you do is they'll give you an inhaler, and then they will have you do the same test again. Now, what do you think would happen if somebody had asthma to their values here? What do you think would happen? Yeah, they should all go back to normal, right? Their problem with an asthmatic is that their smooth muscle is constricting their airways. So you give something that's a beta agonist that relaxes their smooth muscle, your airways open back up, and now everything should appear normal. So if they go back to normal values, these go back to normal, then you'll say you have asthma. Okay?
Is that answer to like why we use the bronchodilator for the obstructive?
Yes. So typically, regardless of why you would come, you would use a bronchodilator. They would just try it out on anybody, even if you had these values, just to see if there's any effect. Because sometimes there's a mixture of obstructive and restrictive disease. It's not usually just one or the other. The way we kind of talk about it in class is usually one or the other, but it's not usually like that. Okay.
So bronchodilator wouldn't help the restrictive disease.
Bronchodilator will not help somebody with an exclusively restrictive disease because their problem is a problem with the tissue. It's too stiff. And so giving somebody something that's going to dilate their airways should already be open and dilated. Okay? And so that should not help them. Okay. Good. Anything else? All right, so let's go. Is it okay if we transition to reproduction? Okay. So we have only about 20 more minutes in here, but then we'll see we'll have to go back down to that room. And I don't know what we can possibly do, if we can move a table out or do something that can accommodate more chairs. I don't know, we'll figure it out, but just an FYI, that's what's gonna happen in 20 minutes. If we get kicked out of here. Okay, now, what do you guys what do we want to talk about again for repro?
The level of estrogen.
Oh, estrogen, okay, estrogen. All right, so let's just start there. All right, so let's first start with the 3-tiered system because I remember that was a question, okay? So 3 tiers. I'm writing this so that I can kind of keep it track of the time here. Okay. So we have tier 1, which is what part of the body? Hypothalamus, good. We have tier 2, which is what part of the body? Or posterior pituitary. Okay, and our tier 3 is out in the periphery. Okay, now this is typically called what kind of hormone? Releasing hormone. Okay, this is typically called what? Stimulating hormone. And this is typically called what? Peripheral hormone. Okay, now, in general, this is the flow. The releasing hormone is released. It stimulates tier 2 to release a stimulating hormone, which stimulates a tier 3, a tissue that will produce a peripheral hormone. Okay, and the peripheral hormone feeds back negatively. If the peripheral hormone becomes really high, then you don't need any more stimulating hormone, so you turn that off. If the peripheral hormone becomes really high, you inhibit the releasing hormone because you don't need any more releasing hormone, because you don't need any stimulating hormone, because your peripheral hormone levels are high. Does that all make sense? Now, if your stimulating hormone levels get really high, if you have stimulating hormone around, it's kind of thought you will be producing peripheral hormone. Does that make sense? So stimulating hormone, you should be creating peripheral hormone. So if this goes up, you kind of shut down releasing hormone because you theoretically don't need any more of that either. All right? So high levels of stimulating hormone will inhibit releasing hormone. High levels of peripheral hormone will inhibit stimulating hormone and releasing hormone. Does that make sense? All right, now, the other thing to recognize are that these structures are monitoring the plasma. Now, these structures are monitoring, so a peripheral hormone, let's say estrogen, these structures are monitoring estrogen levels in the blood. When estrogen levels in the blood go up, you shut down the other systems, right? Okay. So I'll come back to that because that's kind of important in a second. And I think it makes sense when I say it, but sometimes you might forget about it. Okay, so estrogen levels. Estrogen is produced in, here's your little ovary. And inside of your ovary you have your little follicle with the little egg. Now, estrogen, that's where estrogen comes from. So estrogen levels are low at the beginning of your female cycle. If estrogen levels are low, then which part of the brain, or what do you want to turn on? Say it all together so everybody knows what we're stimulating here. What are you stimulating the release of? GnRH, okay? And where does GnRH come from? Hypothalamus. So you get increased GnRH production from the hypothalamus tier 1. GnRH goes to which one? AP or PP? AP, okay, anterior pituitary. And you secrete what hormone? Okay, LH, FSH. Now, inside, so, and this might not have been clear, I'm trying to color code it in your pictures, in your packets. There's 2 layers of cells here. You have one that are your theca cells, here, in blue. And in black here, I'm going to just darken. You have multiple layers of thickening granulosa cells. As more estrogen is produced, those cells proliferate. So here are your granulosa cells, here. Granulosa cells, theca cells. Okay, now, FSH leaves the hypothalamus, goes to the granulosa cells. Luteinizing hormone leaves the hypothalamus, leaves the anterior pituitary. Did I say hypothalamus before? Leaves the anterior pituitary, goes to the theca cells. All right, the theca cells, what do they do after they're stimulated with LH? What's the main thing they produce? Androgens. So they produce androgens, which are what? it's a precursor to estrogen. I'll just assume that's what people are saying, right? Precursor to estrogen. It's like an estrogen backbone. So now you have a backbone to estrogen, which diffuses over to a neighboring cell. See how they're right next to each other? Diffuses over to the granulosa cells, and the granulosa cells respond by producing what? Estrogen. Now, this is all happening inside of the ovary. Do you see how inside of the ovary estrogen levels start to rise? Now, estrogen levels have to start rising and rise to a level where it can eventually be high enough where it starts diffusing out into the plasma. So the amount of estrogen in the plasma is basically the amount that leaks out of the ovary and moves into the plasma, okay, as it starts to accumulate in the ovary. Now, estrogen present in the ovary, do you see how estrogen will be higher concentrations in the ovary? Because that's where it's being produced, just like CO2. So estrogen in this granulosa cell that's being produced moves over and stimulates other granulosa cells to divide and stimulates them to start producing estrogen too. Does that make sense? So do you see how a little bit of estrogen produced in this environment can stimulate cell division and more estrogen production all inside of the ovary right here? Okay? Now, what ends up happening, so now more estrogen levels in here are rising. Okay? So now estrogen starts leaking out, and estrogen levels rise back up to normal levels from where they were. They're originally low. Does that make sense? Now, I'm going to say low levels, normal levels, which is going to be the same as our mid, because that's our middle level that we talked about. There has to be a middle. And we also can have high levels. Now, when estrogen goes from low, where it was in the beginning, we stimulated this reaction, goes back up to normal levels, what happens to these pathways? They get turned off, right? Negative feedback. So, estrogen comes back, inhibits LH, inhibits GnRH. Now, we don't talk about this that much, but these little granulosa cells can also make inhibin when estrogen levels get too high, and those can inhibit FSH. Now, I don't really want you to focus on inhibin here because inhibin levels change throughout the cycle, and so that's why I don't even draw it in. But if somebody were to ask me that question, where is inhibin on here, that's where inhibin would be, yes.
So have you ever get past the mid level range of estrogen?
Yes. Inhibited, right? Okay. So what happens, that's the original question. So what happens in this local environment is that this estrogen is enough to start stimulating more estrogen production independent of this. So this gets shut off, but there's already a high concentration of estrogen here, so it goes around and starts stimulating the division and production of estrogen on its own, independent of the brain, okay? Kind of like a positive feedback cycle. So estrogen starts stimulating cell division. Now, that's really important, because what you have to have happen is those granulosa cells, remember, and those theca cells are going to become what structure after ovulation? The corpus luteum. So you have to make sure that the granulosa cells and the theca cells, that there's enough of them to create a healthy corpus luteum. So do you see, this is actually like kind of a beautiful system. I hope somebody's hovering out there. Okay, so if you have, what happens is you need to ensure enough cell division. These are the cells that start producing progesterone and estrogen later on. Okay, so let's make sure that we build them up enough before we ovulate. Now, as they build, do you see how estrogen is used as a signaling molecule? As they thicken and more of these cells form, estrogen levels start to rise in the ovary. And as it rises, it will rise to a certain level. As they divide, produce more and more estrogen. Estrogen levels, more estrogen will start diffusing out, even though the system is shut off, and estrogen levels will really start to rise. Now, at that point is when there's something weird that happens. Instead of inhibiting GnRH, LH, and FSH, it stimulates the hypothalamus to produce more LH. Now, this is cool because what happens is estrogen now feeds back positively, activates GnRH, and it actually causes definitely more selective for LH, causes a huge burst in LH. Okay? Now, LH levels increase, and that signals for ovulation. This is beautiful because that means when you have enough estrogen around, that can only happen when you have enough granulosa cells around. Does that make sense? And when you have enough granulosa cells around, now you have a corpus luteum that can be healthy and able to produce progesterone. So this little follicle, basically, when it reaches the right size, tells the brain when to ovulate because it's ready. So estrogen becomes a signaling molecule that says, okay, we are ready, you can release the egg because the corpus luteum can take over. And I just think that's so cool. Okay. So now do you see we ovulate? Now, when you ovulate, the egg breaks through the outside of the ovary. That's why it can be a little painful when you ovulate. You're rupturing your ovary. So that egg leaves, this structure stays behind. Okay, does that make sense? The granulosa cells and the theca cells stay behind and they become the corpus luteum. Now, where does this little egg go? Where? Into the fallopian tubes. And the fallopian tubes lead to the uterus. Does that make sense? So now this little egg enters into a little tube, okay, that will feed into the uterus. Okay, now it's about right here where it meets up with a sperm, and let's say it gets implanted, or let's say it gets fertilized. So now we have a fertilized egg sitting in. Okay, the other thing is that's okay. Yeah, we'll get to that point. Okay, we have a fertilized egg. This fertilized egg is sitting kind of in here now, fertilized, and over the course of the next 5 days or so, it starts progressing, making its way into the uterus, where it will implant. Once it is fertilized, what hormone does this cell start producing? HCG. Now, where does HCG have to go? Can it just diffuse over to the ovary? No, it cannot. Okay, it has to enter what structure? Where does it have to go to deliver it? Plasma. It has to go into the blood, right? So this little guy says, I am fertilized. You start producing HCG. It makes its way somehow into a bloodstream somewhere. Okay? Now that HCG will go all over the body, come back to the ovary, and signal to the ovary, corpus luteum, stay alive. Now the corpus luteum will produce 2 hormones. What are those 2 hormones? Progesterone and estrogen. I'm going to erase this. So we have our little corpus luteum here, and it's secreting progesterone and estrogen. Now, in your worksheet, I'm just going to turn this so that people can see. In your worksheet, I show that progesterone, what is the main function of progesterone? Differentiation of what tissue? Endometrium. So progesterone goes into the blood, travels all over the body until it gets to the endometrium here, and it says, oh, we need to ensure, so at this point usually we're still in the fallopian tube. Progesterone starting to be produced, and we go to the endometrium and we say, start making glycogen, because we might have an implantation event. And we need some food for this little embryo to eat because it doesn't have a blood source yet. So we produce glycogen here. All right, what does estrogen do? And what did estrogen do also? I showed you what it did inside of the ovary, but what does it also do inside of the uterus? Proliferation. Inside of the uterus, it causes the uterus to thicken. So again, not only do we have differentiation, but we have a thickening of the endometrium. Okay, so now we have 2 things. Now, this little corpus luteum producing progesterone, that's coming here and saying, differentiate, make glycogen. Estrogen's making sure that this endometrium does not shed, and we don't lose the endometrium. Now is when I should have talked about HCG. Okay, so now as this should have already happened, as this little egg makes its way, it's fertilized, it starts producing HCG, comes back to the ovary and says, corpus luteum, do not stop producing progesterone and estrogen. Because what would happen if estrogen and progesterone were stopped being produced by the corpus luteum? Yes, you would shed your endometrial lining and out would come the egg, the fertilized egg. And all this work that you tried, that you put forth to get this fertilized egg would be lost, okay? So the egg would come out. So it's critical that this thing does not stop producing progesterone and estrogen. Really important. That's one thing. Now, progesterone, what happens to GnRH and FSH and LH? Progesterone can act on these tissues to do what? Increase or decrease these levels? Decrease. So negative feedback, inhibition of the anterior pituitary and of the hypothalamus. Now, why do you think that's important? Why would you want to inhibit GnRH and FSH in this scenario? What if LH levels went up really high? You could ovulate again. Do you remember that when you develop follicles here, you don't just develop one, you develop multiple. And if you develop multiple, you might have another follicle that potentially could be ovulated. And so if LH levels go up high again, you could potentially ovulate again. And so what we're doing in this section of the graph that I have is we're trying to give this little egg a chance to become fertilized. So we don't want to ovulate again. We want to see if this little guy can get fertilized, and if so, it'll fertilize, implant, and we'll be fine. Okay? The other thing is that pregnancy takes a lot out of your body. So evolutionarily, our bodies have been designed to kind of take on one pregnancy at a time. So the idea that we would carry triplets is not very physiological because it's really hard on your body. And so you want to secrete one egg at a time. That little egg has the potential to be fertilized. We give that one a shot at, developing into a human. And so we shut off these systems to prevent a second ovulation. Does that make sense? Now, now progesterone, estrogen maintain. If pregnancy does not occur, then what happens to the corpus luteum? Becomes the corpus albicans. And what happens to the amounts of progesterone, estrogen? No estrogen, progesterone. What happens to your endometrial lining? Sheds. Goes away. Does that make sense? Now, you begin at the cycle again. If this thing isn't producing estrogen, what do you think happens to estrogen levels in the plasma? Up or down? It starts going down. So estrogen levels start falling over time. And now estrogen levels are low and you stimulate GnRH production again. Progesterone can't inhibit anymore because there's no corpus luteum. Does that make sense? So you release the inhibition, GnRH starts being produced, and now you're at the beginning of your cycle again and you try and bring up another egg that you can potentially fertilize. Makes sense? Yes?
With exogenous hormones, so they inhibit the LH, FSH, and GnRH, but wouldn't the granulosa cells still be dividing, which means estrogen can still go up? So then how does ovulation not occur if those are still?
So the question is, if you take the pill and you inhibit, why couldn't the granulosa cells start producing estrogen on their own? Remember, they need the initial stimulus. This is why they don't tell you to have sex right after the day after you take the pill. Okay? Because that could happen. What can happen is maybe there's enough estrogen to activate your granulosa cells, they divide, and now you activate the LH spike because that had happened. So you take the pill for a month, and then they say, okay, now you're okay, because after a month, you kind of slowly shut down the system, and estrogen levels should stay at a constant level which should never initiate the LH spike. Good question. Yes? Not when you're on the pill, you do bring up a set of cells, I'm sure, but there's less dividing, and those cells don't end up having enough stimulus, estrogen stimulus, to actually initiate that cycle, that positive feedback cycle, and reach the LH spike. Yes?
So if you take the pills that don't have the estrogen in it, is it acting as if the corpus luteum was secreting progestin and just stopping it that way?
Yeah, so a lot of contraceptive pills have progesterone and no estrogen at all. And all that is doing is just shutting off the system, just like as if there was a corpus luteum around. Okay? That's secreting progesterone. Exactly. Yes? So the follicles never leave the ovary, and you undergo atresia. And that just means that those follicles basically disintegrate. They get reabsorbed into the body, okay? And it's also thought that women who are on the pill for a long periods of time, do you see how you never break through the ovary because you don't ovulate? It's thought that they also have lower cancer rates because of that. So they've done studies in nuns who never take the pill, and they have higher rates of cancer, and versus women who've been on the pill for a really, really long period of time, which is kind of interesting. Anyway, yes?
So when you're on the pill, your menses is anovulatory, just like it would be.
Correct. You may have enough estrogen around to build up a little bit of your endometrium, but you do not have enough estrogen around to initiate ovulation. Correct. So your period might get lighter when you're on the pill because your estrogen levels have now been reset to a lower level than what normally would have happened, okay? What your body normally would be producing. That make sense? All right, I should double check that people aren't here. I should put my shoes on so I look a little more prepared. But yes, I will post them. I may have to post them in 2 sections, but